All right, thanks. What a great turnout for like the last day of SAGES. So this talk is really, I think, probably designed to unwind my complicated relationship with Dr. Goldberg, perhaps, because we find out that we have a lot of things in common oftentimes, and we think and have interest in the same areas, but we find ourselves sometimes at odds. And we're actually going to come together and write a book together for SAGES on health policy and advocacy. So in some ways, this was an opportunity to kind of navigate that, and we're going to divide the book up into two parts, health policy and advocacy. So I think that's probably where the kernel of this idea came from for this talk. So I'm going to talk a little bit about, I think, what's a different perspective on this topic. This is the first time I've ever been invited to speak on a panel with people who do advocacy. But I do think there is great value in bringing people together from different perspectives, and we've talked about that. So I think that's the spirit of my talk. I have some conflicts. I have research funding from NIH and AHRQ to do health policy related work, and I own a company that does software for profiling hospital quality and costs. So my perspective on what is advocacy? Advocacy, as you've heard, I think from my perspective, is generally a perspective of a single group. It is, by definition, a special interest group. And I know that seems like a dirty word. It's not a dirty word. It's a specifically inclined group. They have a certain perspective that they bring. In general, when you say like the American College of Surgeons, Political Action Committee, et cetera, it is looking after the interests, our interests, of surgeons and the patients that they serve. For instance, in the face of payment reform, as you heard, like updates to the RUC committee, the FLAP code that he was just talking about is essentially the entire profit margin for my division. So this is something that I do care about, and I'm really excited that we have people on the front lines taking care of that. That being said, I don't spend my time there. I spend my time more here, thinking about a societal perspective in health policy, and that is healthcare and money in general. The money that we spend on healthcare is a scarce resource. Right? And when we think about from a societal perspective, how do you allocate a scarce resource across people? It's not necessarily about the surgeons anymore. It's about dollars and American people, right? And so what policies do we put in place to ensure optimal outcomes and costs? So on the last slide, I had the flyer for the American College of Surgeons Health Policy and Advocacy Conference, where a bunch of surgeons come together to go and meet policymakers. In my world, we go to the National Health Policy Conference, where there may be one surgeon represented there, and a lot of other people. It may be our next surgeon might have been there or be there, and we meet with policymakers to talk from a societal perspective. And it's interesting because you see how surgery fits into the larger dialogue about the allocation of resources across healthcare, and it's important to have that in mind. I think the bottom line, the difference is that nobody really is feeling sorry for surgeons, right? Like, yes, it is important to have people like Dr. Seltzer out there helping us keep bread on our table. But very few people are out there thinking that surgeons don't have enough bread on their table, except surgeons. And so oftentimes when you're in mixed groups like this, you have to be careful how you phrase things and how you say things, because we do win the RUC battle. When you're standing next to a primary care doctor who is in clinic all day, like, yes, we have burnout in our profession trying to maintain our salaries so that, but when you're trying to run a primary care practice, it's an even more stressful situation. So that's kind of, it's a relative thing. And yes, we are in charge of the RUC committee runs the relevantism, but I think we've won that battle or are winning that battle, at least from that perspective. And I'm not saying I'm sad about that, okay, to be clear. But I think one thing that we definitely lose out on is that surgical care is a huge part of healthcare spending. And we don't have a lot of people working on policy making and doing policy research and studying surgical population. So I think we're doing pretty well in advocacy, and thank God we have people doing that, but we have less people thinking about how we play into payment reform, for instance. And we'll hear about that next, and I'm not gonna go into that because we have a speaker on that next. But so what are the kind of questions we look at? What is the impact of these policies that are out there on surgical populations? Really what works and what doesn't work? Like, I'm really interested in that question. Yes, Medicare is doing accountable care organizations and bundled payments. Are they working? Are they not working? Are the incentives trickling down so that we can reform care? And I'm ultimately interested in improving care delivery in response to these incentives, or helping understand which incentives work and which ones don't. And perhaps most importantly, what are the unintended consequences? Because we see a lot of unintended consequences when policies roll down. And I think this is an area of common ground between advocacy and health policy research for sure is when things are coming down and landing on our shoulders in terms of regulatory burden with no benefit. That's absolutely common ground between advocacy and health policy research. And the reason why I moved it into phrase from health policy research, is because that's the land that I live in, and that I think is an area for surgeons to get more involved in. It's not really exciting, like curing diabetes or something, I think. A lot of people aren't necessarily drawn to health policy research, but it provides important evidence for policymakers. So this is an example. This is one grant that I have right now, and I've had it, this is the second iteration. I've had it for about 6 or 7 years now, where I'm evaluating the policies that impact surgical populations in Medicare. So we evaluate newly adopted policies. We look at their impact on surgical outcomes, spending, and then we explore unintended consequences. And the most recent iteration looks like this. We're evaluating some policies you probably have all heard of. We're doing a kind of rigorous evaluation of the Hospital Readmission Reduction Program on surgical populations, the Hospital Acquired Condition Program. We're looking at bundled payments and the programs that are implemented specifically around those, and then accountable care organizations, specifically the Medicare Shared Savings Program, and whether or not that improves care. I think we have early results in on that last one, and it's pretty much clear that these haven't improved surgical spending or improved quality for accountable care organizations, and we know that's probably why, because no one involves surgeons in those discussions about ACOs. They're primarily related to primary care and primary care reforms. And I remember I talked to the director of our ACO about, I'm like, oh, what do you have going on in surgery? He's like, well, that's a great idea. We should do something in surgery. And I think importantly, and as I said before, we explore unintended consequences. We don't necessarily look at the unintended consequences for surgeons. We're looking at the unintended consequences for patients. So once again, a little different perspective. Both are important, but we're more interested in what happens to vulnerable populations. Are these penalties that are related to these policies landing on hospitals that serve vulnerable populations in a way that hurts those? And in general, the answer to that is they do. We end up taking hospitals with poor performance that serve lower income patients, for example, and they have lower margins. And we end up piling up penalties on those hospitals and giving them to the hospitals that are generally in favorable payer mix areas, which does harm. We call that the reverse Robin Hood thing, where we steal from the poor and give to the rich. So an area to keep an eye on for payment reform. And I think as someone who is a health policy researcher, I think it's a great gateway to get involved, to think about becoming a policymaker. This is Lena Chen, who's actually an internal medicine physician, who was one of my very first K Award mentees. And her K Award was around understanding variation in hospital performance, both in terms of quality and costs. And now she has an R01 to study the effects of accountable care organizations on post-acute care in medical populations. And she also now splits her time 50-50 at Health and Human Services in ASPE, which is the evaluation and kind of policymaking arm of HHS. They write their reports to Congress, et cetera, on how to change policies to make them avoid problems like that issue I just mentioned on vulnerable populations. For instance, they just wrote a report that Lena was involved with that is going to lead to modifications in how the penalties fall on vulnerable or hospitals that serve vulnerable populations. So it's a great way to think about launching a career if you want to have one foot as a policymaker. If you're not interested in policymaking, I think it's also a really great way if you're interested in becoming a health system leader. As a health system leader, you need to be literate in health policy. And these are just examples. One of my faculty members who right now is Hari Nathan, who's studying ACOs and surgical populations and wrote the paper that I just mentioned, and one of our research fellows, both of which aren't necessarily interested in policymaking, but do want to be health system leaders and be literate in health, not only health policy, but also understanding data and analytics. And for those of you who are involved in this at the health system level, one of the decisions that hospitals go through when they're trying to figure out whether or not to participate in these bundled payment programs is they look at their Medicare data. They look at it and see what their current spendings are and model how they're going to perform under the policy and see whether it's worthwhile to sign up for voluntary payment reform. And those analytic skills are difficult to master. And having one foot in the policy research world is a great way to understand that and then build up a kind of a skill set to then transition to being a health system leader. I'm going to give you a story of some policy research I did that actually put me at odds with the advocacy of one of our professional organizations. So it's a good example of where we don't have common footing sometimes. And then I'm going to close with where we do have common footing. So this is I see some people smiling in the back. Some people know this story. So yeah, they're laughing now. So this is the CMS Medicare National Coverage Decision for bariatric surgery. So several years ago, the American College of Surgeons and the ASMBS, which was the ASBS then, decided that they would, or the CMS decided that they would only pay for bariatric surgery if it was done in an accredited center by those organizations. There was 2 accreditation programs at the time. There is now 1. And the accreditation was, to be honest, tied to volume. Volume criteria was the only thing that could ostensibly be linked to performance per se. There were a lot of structural criteria and some process criteria, none of which have been proven to be associated with outcomes. Volume was the only one that had been proven. And so as someone who studied volume outcome, I thought this was great. This is like someone's finally putting some teeth in volume outcome relationships. This is so great. I'm so excited. Yay. And so I was really excited about that. Nobody believes that, but it's true. And so the policy rolled out, and I did an evaluation, and this was part of my first R01 grant in health policy, and this was like AIM-1 or something. And so we did a formal, rigorous evaluation of that, and what we found, I'll show in a second, was no benefit. When I submitted this to JAMA the first time, we showed a benefit, and it was basically showed that there was a strong secular trend, but there was a benefit. And then our statistical reviewers were like, oh, but you forgot to do this. And I was like, oh yeah, we did forget to do that. And when I did that, I'm not gonna tell you what it was because you don't care, but I did that and then the effect went away. So like, I was like, oh, well, I guess that, my goal was, I was trying to find the truth here, right? But my original thing was like, well, I'm gonna send this in, I'm gonna go to the ASMBS meeting, they're gonna like hold me up like Rudy at the end of that movie with Notre Dame, and everyone's gonna love me, and it's gonna be great. But then when we did the analysis right, it was negative, and ultimately that's what they published because they're interested in the truth. And so, the statistical truth. So we published this, and what we showed. We showed that outcomes are getting better in Medicare patients and in non-Medicare patients, generally at the same rate. Non-Medicare patients weren't necessarily exposed to this mandate that they have to have surgery in COEs. I think if you look at this, you can see the dotted line, the vertical dotted line is where the policy was implemented. You can see that care was getting better. And what you don't see, this is serious complications here. What you don't see is mortality, because mortality had disappeared by the time we even did this analysis. So mortality was a problem 10 years before this and had been written about and published about, and it was in the newspapers, but mortality itself had gone away before anyone even had an idea about this policy. So that shows you how fast care was improving. And so interesting, so we decided to explore the unintended consequences, as I said, a really important part of being a health policy researcher, right? So we followed that up with another JAMA paper where we looked at the impact of the policy on access for minority patients. And this is what that showed. We essentially showed that there was a 20% decline in availability of bariatric surgery for minority populations after the policy. So as a policy researcher, I look at this and I say, okay, the policy had no measurable impact. The mandate had no measurable impact on improvement in outcomes, had a very measurable and profound decline in access for vulnerable populations. So what should you do? It's not a good policy, right? We should get rid of that policy. Well, this is where I got kind of up against the advocacy arm of ASMBS, and we wrote a letter to Jaime Schaefer, who is the director of Division of Medical and Surgical Services at CMS, and we said, we have this new evidence that you should consider this, and they did. They reopened that coverage decision to think about it, and they basically did an evidence review and posted it all online. And the interesting things about that was, I would say that the people that are making these decisions, they're PhDs in health services research, they're health policy researchers. They care about the quality of the evidence. So when you're debating in a public forum, and you can kind of twist evidence however you want, they care about the quality, and they care about how you constructed your statistical models. So that actually does matter when it comes to policy making like this. They really do care about the quality of the evidence. And so they put it up for public comment, and I'll say there's about a 1/3, 2/3 of the public comments, in terms of 1/3 were not in favor of our view that this should be reversed, and 2/3 were against it. This is an example of a comment that was for it. They kind of say, this is once designated a COE facility, we showed no interest in supporting surgeons' requests for quality improvement. Our outstanding outcomes were just as good as prior to designation, therefore not really justifying the hype. This is kind of a typical thing that was for overturning it. Now this was a typical comment against it. And the only comment I'll make about this is that this was a form. And this is really interesting from an advocacy perspective. For those of you who do advocacy work, this was like a form statement. And you get these, right? You get them, they send it out from the, from the advocacy groups for societies. They say, here's a form, fill this out. So when CMS reviewed this, they said, this is a form comment from the society. We will count all of these as one. So there were like, I don't know, 600 of these, and they counted them as one. And they said that in their final decision on this, they did that. So it's a good thing to know, when you're doing advocacy work, you say, hey, customize your response. Otherwise, you might only get counted as one. And so they ended up eliminating that requirement. And which sounds great, right? You publish some data, you do some advocacy work on behalf of your evidence, policy responds. But I will say we won the battle, we lost the war, because private insurers still marched forward with COE mandates. And so by the time I think we got done with all this, 99.9% of hospitals in the United States were centers of excellence. So once again, pretty much lost that battle, or lost that war. And I'll tell you that the private payers are much less interested in rigorously reviewing evidence. Why do you think that is? Well, they don't have the infrastructure that Medicare does to rigorously review evidence. But the other thing is, anything that restricts care is fine with insurance companies. Private insurers love to restrict care. That's like what they do, right? That's like how their business model works. So they weren't necessarily they were interested in listening to an evidence-based argument. So why did this fail? We did more research. Most of the improvement was due to secular trends. I already made that point. There's a weak volume outcome relationship for bariatric surgery. And then resource-poor hospitals, we found, couldn't afford the process. So that's the story of where we sometimes can be at odds. And like I said, I think the outcome was the outcome. But I think we do have a lot in common, and we care a lot of the same things, health policy researchers and advocacy supporters. And I think, and Gamey's talk highlighted a lot of that. There was like nothing in your talk that I disagreed with at all, or in Don's talk. I thought they were great. We need to be involved in the process, and there are some areas where we have complete and total overlap. But I'll tell you, the one thing that we all really care about is health policy literacy. And we all want surgeons to be literate in health policy and to participate in the process. I want you to participate in the process of research and evidence generation. They want you to participate in the political process and the advocacy process. So I think we all have that in common. And I think we all care a lot about unintended consequences. And I think we all care about if something doesn't work, we need to modify it or get rid of it so it does work. Because besides burnout, I think regulatory burden is a huge issue for surgeons, and something that we would like to get rid of as much as people who are focusing on advocacy. So how can we work together? I think like this, create combined forums where we can have some constructive conflict every once in a while. I think when you have a disparate opinion from somebody, cutting them out of the conversation is not always a productive thing. I think when you come together and find common ground, you generally move the field forward faster. So I think combined forums where we can do that and help build health literacy from multiple different perspectives, I think is really important. And then find common areas where we can align evidence with the needs of advocacy, right? Like, we generally don't come to the same forums, so I don't necessarily know what evidence you need for advocacy, right? And it'd be nice to come together sometime and hear what we need so that we can send our young, talented people out there to generate that evidence and bring it to bear on issues that make surgeons better off and make our patients better off, most importantly, because ultimately that's what this is all about, is improving surgical care. Thank you.